Good morning. Thank you for joining this webinar on leveraging behavioral sciences for dementia care. My name is Julie Zasimopoulos, and I'm Associate Professor in the Price School of Public Policy, Senior Fellow at the Schaefer Center for Health Policy and Economics at the University of Southern California. I am Director of USC's Alzheimer's Disease-Focused Resource Center for Minority Aging Research, and also the Center for Advancing Sociodemographic and Economic Study of Alzheimer's disease and related dementias. The center supports this webinar through a grant funding from the National Institute on Aging. The centers are dedicated to supporting innovative social science research on dementia and also supporting the research careers of scholars. And to this end, we offer grant funding and other research training opportunities. If you're interested in more information, please look to the Schaefer Center website for these opportunities. I'm very pleased to be moderating this interesting discussion of how behavioral sciences can be leveraged for better dementia detection, care for persons living with dementia, and improve quality of life for them and their care partners. Today, I'm very pleased to introduce our speakers, Dr. Joanna Lee Hart and Dr. Lisa Walk. Dr. Lisa Walk is Chief of the Division of Geriatric Medicine for the Perelman School of Medicine at the University of Pennsylvania. Under her leadership, the division is improving the quality of care provided to older adults, advancing clinical research in Alzheimer's disease, health disparities, sleep disorders, and the interface between socioeconomic status and disability. She is also importantly educating the next generation of healthcare professionals on fundamental geriatric principles. Dr. Walk's scholarship focuses on improving health outcomes for older patients through the implementation and evaluation of innovative care delivery models. Dr. Joanna Lee Hart is Assistant Professor of Medicine and Medical Ethics and Health Policy at the University of Pennsylvania, where she is also an attending pulmonary and critical care physician. Her research focuses on complex medical decision-making. She has particular research interests in empirical bioethics, expectation formation, physician attributable variation in care delivery, and health equity. Welcome to both of you, and thank you in advance for participating in this webinar. Now I will turn it over to Dr. Hart for her presentation. She'll be followed directly by Dr. Walk, and we encourage participants to post questions in the Q&A box. I will turn to questions at the end and do my best to answer as many of the audience's questions as possible. Dr. Hart, I welcome you.
Thank you. It's a pleasure to be here today. I'm very excited about getting to speak with all of you. I am an assistant professor at the University of Pennsylvania, and I am not primarily a dementia clinician, but I am a pulmonary and critical care physician. So I do both inpatient and outpatient medicine. And I spend much of my time thinking about how we might improve the care that we give to people, particularly people who are faced with serious illness, using behavioral science. And so how do we leverage what we know about how people behave to improve the care that they receive when faced with these tremendous life-changing diagnoses and conditions? So when we think about people, we think about sort of human feelings and emotions, and that we're not sort of robots. But we often, when we're thinking about approaching improving care, thinking about people as humans gets very messy very quickly. Because how do we measure how emotions and feelings and behaviors influence the care that we receive, the decisions that we make, the way that we experience life, which is ultimately typically the goal of healthcare, is improving how the experience of life and health is for the people who healthcare touches. And so if we think about people as rational decision makers, then the goal for those rational decision makers is really around maximizing utility. So when faced with a particular decision, we have to know all of the outcomes, we have to understand the value, and our hope is to maximize the value of whatever ultimate decision we end up making. So I often use the example of whether or not to take an umbrella with me when I'm walking to work. I commute as a walker, so I have to walk to work just over a mile each way. And so whether or not I have my umbrella on a rainy day can make a huge difference in terms of my quality of life, my professional appearance when I get to work, and so forth. And so if I was a rational decision maker, if I didn't have human thoughts and bias and emotions, then I would simply stand at the front door, think about all of the potential outcomes. If I do take my umbrella or if I don't take my umbrella, the probability of rain, how I'll feel if it rains and I don't have my umbrella, the cost to me if I have to carry an umbrella around all day and it ends up not raining, the value that I'll feel if it does rain and I do have my umbrella, and on and on and on, all of the permutations of the possible outcomes of that. How easy would it be for me to buy an umbrella on my way home if it did start to rain? How much would that umbrella cost and how worth it is that? And so this is how a rational decision maker might approach that decision of whether or not to take an umbrella when I walk out the doors on my daily commute. But the reality is we're not rational decision makers. None of us have time to stand at the front door and debate whether or not to take an umbrella with us for 15 minutes. And furthermore, we're not very good at anticipating how we might feel in the future if we don't have our umbrella and it rains, or if we do and it does. So with rational decision making, well, it seeks to maximize utility. It requires that we know all of the possible available options. I know how much the umbrella costs at the bookstore and how far out of my way it would be to go to the bookstore. It means I know all of the probabilities. I trust the weatherman. The weatherman has absolute knowledge of whether or not it will rain or not, and whether or not it will rain during the particular times of day I have to be outside. And I have to have well-established and fixed preferences, which is really critical, particularly in something like dementia care, where preferences might not be fixed. People might not have gone through this before. They might not know what to expect or how it'll feel once that reality occurs. And we have to have the time, attention, and cognitive ability, or even just bandwidth, to stand there and make these decision trees for every rational decision we hope to make. And so thinking about how this might work for a medical decision, the decision whether or not to treat atrial fibrillation with anticoagulation or blood thinners to prevent clot might look something like this: weighing whether or not they'd have a cardiovascular event against the idea of having a side effect from bleeding from taking the anticoagulant. So you wind up with all these numbers, and you have to have, in order to come up with those numbers at the end on the far right side of this, the patient has to have values or utilities for each of these health outcomes. But of course, the patient's probably never experienced any of those health outcomes before. And so coming up with a number, how much is it good or bad? What value do I place on that particular outcome? Can be rather challenging or probably impossible for most of us as healthcare decision makers. And so there was a large body of literature, and there continues to be, development of decision aids. And decision aids have their role, and they can be very important in certain contexts. But the provision of information is essentially promoting rational decision making. And we know that it improves knowledge, and knowledge is really important when making really critical decisions in our lives as healthcare decision makers. But we know from this large body of literature, the decision aids generally don't have a strong effect on behavior, what actually people decide to do, how they actually feel with those outcomes. And so while decision aids are promoting that rational decision-making model can result in increased understanding of the risks and benefits associated with a treatment or a healthcare decision, it can make us sort of take time to feel more clear about the relevant personal values that should go into that decision. And it may improve our accuracy of risk perception, but there's a lot of bias and cognitive sort of gymnastics tied up in risk perception. And so ultimately, decision aids and sort of promoting that rational decision-making model often doesn't improve choices and often doesn't change outcomes. So if information and supporting decision-making in this sort of rational decision-making model isn't the key to sort of improving the many things in clinical care we might choose to improve or want to improve or seek to improve, we instead have to step away from that rational decision-making model and start to think about how people behaviorally differ from sort of that rational decision-making model, that sort of econ, that robot that's focusing on sort of these healthcare values and maximizing utility, and recognize that we are humans and we have feelings and emotions. We have loss aversion, we have regret. We try to minimize regret. We have limited attention span and limited bandwidth to make millions of decisions that we have to make over the course of a day or a week. And so how people and groups actually make judgments and decisions is using something called bounded rationality. So we're not completely irrational. We're still trying to maximize value, but we put constraints or limits on the number of options that we think about, the number of ways that we build our decision-making trees through heuristics and biases. And so that limits the amount of cognitive load we have to spend on any one decision. It limits the amount of confusion that we have, by putting these constraints on our choice sets, on the things that we use to make decisions. But of course, that can also lead to problems. That can introduce bias, that can lead us astray, and we can make decisions that might not maximize our actual utility, that might be counterproductive for us, that might not be value aligned or preference aligned. And so an example of this is on the clinician side, is demonstrated very nicely in a study that was done a few years ago among actual medical residents. And presenting a very short stem, a 72-year-old man with advanced multiple myeloma and dementia was admitted to the hospital with a sudden change in mental status. If he develops renal failure, anuria, acidemia, indications for renal replacement therapy, would you begin dialysis in this patient? And certainly we need more information to answer this question either way, and I am fully appreciative of that, and I hope that was your first response as well. But the residents were randomized that in the STEM, either the patient was labeled as being full code, meaning full, no limitations on life-sustaining therapies, or DNR, DNI, meaning do not resuscitate, do not intubate. The patient at some point, maybe with a caregiver, had decided not to pursue mechanical ventilation and resuscitation or CPR if the patient's heart were to stop. And I've presented this similar slide in group settings before, and we're somewhat limited by the webinar setting, but I'll say typically, what do people anticipate to have happen? So take a moment and kind of jot down, what do you think the differences are in these groups? And then what might be problematic if you think there are differences? And usually people get it right, that 72% of the residents who saw this person as being full code would offer dialysis and begin dialysis. And only 38% of the people who saw that DNR, DNI status would do the same. And of course, the reason why that's problematic is because the DNR, DNI order, yes, I want some limitations on care around intubation, and mechanical ventilation, and resuscitation, don't speak to dialysis at all. And so absent sort of that more nuanced conversation with the patient, there really shouldn't be a difference between these two circumstances. But because the residents who are answering this, as might happen with clinicians, sort of anchor on the available information that, oh, well, the person has some treatment limitations and therefore a dialysis would be a step too far for this patient. This might be value or preference discordant for them. They assume that this also extends to dialysis. And so when we think about how we might change this, how we might use what we know about healthcare decision makers, clinicians, patients, caregivers, people who construct healthcare policy, we have to think about the choice architecture. So choice architecture is a term that talks about the design of choice environments. So anytime we're faced with a decision, be it small or large, we are making that decision in a choice environment. This is a picture from a dementia care unit, and sort of inpatient facility in Europe, I believe in Germany. And there's a huge body of work now, a specialized type of architecture, as I'm sure many of you know, that are focused on how to construct environments for inpatient dementia care, for inpatient sort of facility-based dementia living that are conducive to helping the happiness and the well-being of people living with dementia. And so it might be safe outdoor spaces, providing as much autonomy as possible while still protecting them and still making sure that they're in sort of a safe environment where they might be monitored. They might easily find their way home through color coding of doors, through shops that they can go and purchase items in to maintain sort of that independent living that they might seek or desire or sort of seek to fill out in their lives. And so the important thing to remember with choice architecture, so in the same way that we manipulate the physical environment, the same thing is happening in the sort of choice environment, is that choice architectures have to choose something. So there's no such thing as a neutral choice environment. You have to meddle. You can't design a neutral dementia care unit. There's no such thing. You have to put the building somewhere. You have to put the doors somewhere. You have to put the elevators in the bathrooms. You have to put the patient care somewhere, you have to put the medication boxes somewhere, the nurse's station somewhere. So all of those details are going to influence the way that people move through that space. And in the same way, in the choice environment, the choices that you've made to construct that are going to influence the choices people make. So whether or not I leave my umbrella by the door in an umbrella stand every morning is going to influence whether or not I take my umbrella with me to work. Whether or not I have sort of a weather app on my phone that alerts me every morning about whether or not it's going to rain is going to influence whether or not I choose to take my umbrella. And so in every environment, there's no neutrality. You have to choose something. And this is where the concept of nudging came in. So nudging is an influence, a change in the choice architecture that is intended to change in a predictable way the people's behavior as they're moving through that choice environment without restricting choices and while maintaining that there is a choice at hand. And so this is essentially a way of making decisions about the choice environment that seek to maximize the benefit for the majority of the people. And nudges can be targeted at clinicians, at caregivers, at healthcare systems through electronic medical records, directly to patients through communication. And I want to give you just a couple of really quick examples of what a nudge might look like for clinical care. Many of you are probably familiar with this type of work, but one of the very first studies that was done by the Penn Nudge Unit several years ago now was that they identified the clinical problem as physicians were very commonly prescribing brand name medications instead of the generic prescription. And so in an effort to encourage physicians to prescribe generic medications more often, they changed the default order in the electronic health record. So in Epic, our health record, they changed the default prescription from being a brand name or having no default into a generic default. So it meant when you tried to order a medication for diabetes, the thing that would happen would be the generic form of that medication would pop up and you could quickly order it. And so you can see when they implemented this in November of 2014, very quickly they had extraordinary results. They went from having sort of a majority, but nowhere near 100% of generic ordering to near 100% generic ordering for these various classes of medications. And the reason why I highlight this one in particular is because you can see a really important distinction in the nudge, in any nudge, is that you have to be able to override the nudge. You're trying not to restrict choices. You're not saying you don't get to choose the brand name prescription. You're simply saying it's going to default you because we know predictably you're going to stick with whatever pops up first into the generic form of the medication. But for this is Synthroid, which many clinicians will still prescribe the brand name of Synthroid. And so that didn't have the same dramatic response that it did for the other classes of medications. And thinking about the barriers to overcoming the nudge is really a critical part of designing that choice environment. Nudges to date have really been focused on systematic changes to the environment. They're very popular in electronic medical records, but they can also be used sort of in systematic rollouts of interventions to patients. For example, in colon cancer screening, there can be a default that it's simply sent to your house to have the fecal testing or not. You have to sort of opt in to get fecal testing, or you just opt out by not completing the fecal testing that shows up at your doorstep. So those are all kind of systematic changes to the choice environment. But something that I'm particularly interested in is thinking about how the choice environments are constructed in those one-on-one conversations that happen very frequently in critical care, in my outpatient pulmonary practice, and of course in dementia care. So we looked at 101 ICU family meetings. So the caregivers or the surrogate decision makers or the family members of hospitalized ICU patients with clinicians. And we identified all the preference sensitive decisions that had been discussed in those 101 family meetings. And then we classified each of those decision episodes by the types of choice frames. So the choice environments that clinicians were setting up for family members making these preference sensitive decisions. And we looked at sort of what are the choice frames, what are the choice environments that clinicians are using when they talk to people's family members about these life-altering decisions. And we found that clinicians in these conversations very frequently use default framing. So unless you opted away from this default, that would be sort of the plan put in place. and polar questions, yes, no, which is very similar to a default. You can accept or reject this one option. These frames might not even be truly nudges because they may prevent decision makers from even recognizing that they were making a preference-sensitive decision, let alone being presented with sort of the entirety or even portions of the choice set, the options available to them. So clinicians can ethically use nudges in communication in those one-on-one experiences, but it requires attention to their influence and their limits. So one thing that we typically think a lot about is how do people move through the healthcare system? What are the different decisions and friction points that they encounter? And we have to not only understand the environment that they're moving through and how we may or may not have set that up in an intentional way, or whether or not it's simply a choice environment that exists that we never really sort of thought about the implications of it. But also behaviorally, we have to understand how people as sort of irrational decision makers, as human beings with feelings and thoughts and emotions and biases and these heuristics, are limiting their choice sets, are making decisions based on these things, how they are going to experience that choice environment that we've set up. One thing I want to highlight is that behavioral science alone can't overcome structural barriers. So whenever I'm confronted with a clinical problem, and I encourage you to do this as well, is I think about what are the structural barriers? What are the things that no matter how well we equip people behaviorally, they're not going to be able to overcome this brick wall? And that's a really important thing to think about before we try to use behavioral change to influence how people receive care. And so my recommendations for whatever the clinical problem is that you identify as sort of being really salient, the thing that you're working on, the thing that's upsetting you about sort of the clinical world that you're working in, is to first identify that clinical problem and then explore these behavioral roots and irrationality that might be barriers to improvement of that problem or complete resolution. And what are the barriers to thinking through the possible solutions? And then you can design changes to the choice environment that currently exists, which means you have to understand the choice environment that currently exists, and then think through the downsides of that choice environment. So if we're trying to get people to go up the stairs, we might change the stairs from looking like sort of the least popular option, the thing that's sort of out of your way, tucked behind the elevator, it looks dark and grimy, to something beautiful. But we also have to think about what happens to the people who can't go up this beautiful staircase, and how hard is it for them to opt away from this sort of default that's presented to them in front of the, beautiful lobby of the building. So we have to think through sort of the downsides to nudging in whatever particular direction we've decided to nudge. Who will it adversely affect? How large is the barrier? How hard is it to overcome that nudge? And then implement and observe. Because until we're sort of aware of the choice environments that we're creating for people, it's very hard to recognize how we might be influencing for the positive or the negative. I'm going to stop now and turn it over to Dr. Walk, a good friend and colleague here at Penn, who's going to really bring this to the dementia care world and the dementia care space in a more salient way, because I know sometimes it can be a bit theoretical. So Dr. Walk, the floor is all yours.
So thank you very much, Dr. Hart. And so as you said, my task now that I'm hoping to kind of bring it back to our dementia care and all that was just presented. How do we apply this practically when we're doing care? How do we consider what we've just learned about behavioral science? And how can we then use this to achieve goals that our patients are interested in, as well as goals that we want for them? So I'm going to start that we really need to anchor our tailored choice environments. What would that anchor be? There's a current movement within geriatrics, the age-friendly health system. Some of you may have heard about it. And it's being promoted by the IHI and the John Hartford Foundation and the Catholic Health Association of America. And what they're doing is really trying to formulate and put into words how we can approach what the key elements are of geriatric care throughout the country, throughout every health system that implements this. And the foundation or the basis is what we call the 4 M's. Sometimes you'll hear the word the 5 M's, and I'll explain what that 5th M is in a minute, but everyone agrees on these 4. And the 4 M's are, first and foremost, what matters most to that patient? And then we look at what medication, the mentation, mobility, and those aspects, and trying not to make any of those things worse. The fifth M, which is sometimes used, is multi-morbidity. But I'm going to focus on the first M, and that's what matters. And I would say that's where we need to anchor our choice environments as we're presenting them to patients, and as we view or understand how a patient is trying to make a consideration. That's the main starting point for us. What matters to that patient? And in the case of dementia, sometimes we might need to have the proxy explain to us in their viewpoint what they would think matters most to that patient. So patient priority care is a organization that looks at and aligns care among all clinicians with what matters most to patients. Dr. Mary Tinetti is one of my former colleagues and mentors, is one of the leaders of this program. And she also is one of the main advocates for the fifth M, that multi-morbidity. And so when you look at all of this, starting off with what matters to the patient, and we recognize that patients are really the experts in what they want. And that as clinicians, what we're trying to do is help them achieve their goals for healthcare. So we're the experts in how to get there, but the patients are the experts in what they want. But in order for us to help them get there, we have to start off with what they want and how do we elicit that information. So patient priority care, what they've done is they have spoken to many older adults and tried to distill down what does it mean to get at what matters to a person? How do we operationalize that? And so they've found that there are 4 key domains or areas that older adults come back to again and again when they're discussing what matters to them, what their values are. And those areas are connecting, enjoying life, functioning, and managing health. And so those 4 key concepts together formulate and form the basis for what they feel is important, what gives their life meaning, what their preferences are. And then these questions that they've come up with, that they've vetted to see if the questions get at those 4 domains. So which relationships or connections are most important to you? What brings you the most enjoyment or pleasure? When taking care of yourself, what is most important to you now? And then what do you hope your healthcare can do for you? Personally, I use these questions every time I'm seeing a new patient, and I revisit them along the way during the course of what's happening with the patient. Depending on the individual, and if it's a person living with dementia, people with mild levels of dementia typically are able to answer okay, but even with people who have more moderate or severe levels of dementia, if they can't understand the exact questions, it still starts a discussion of what things are important to you, what do you like to do, what gives you joy, and using that information then forms that foundation for me in terms of choice environments. How do we use that information then when we need to start to make some choices, when we have to make decisions? I will say that of these 4 questions, personally, I will say in my clinical practice, the last one is the one that oftentimes gives really rich information of what do you hope your healthcare can do for you. If going back to Dr. Hart's presentation, if you're talking about that gentleman who had dementia and then goes into acute renal failure, what would you be hoping that dialysis would do for you as that person, or if you were their proxy? And so having that kind of information and then being able to tailor how realistic you think that outcome may be based on your knowledge of the intervention and of that individual's personal health status. So that's, for an example, how I would apply or utilize that information from that question. But let's go to a couple examples so you can see more specifically. So let's say we have an 81-year-old woman. She has moderate dementia. She's residing, however, at home with her daughter and her granddaughter, and they're her caregivers. What drivers may influence when or if she relocates to a long-term care facility? I will say that I created these slides a couple of days ago, but I literally just had this conversation with a granddaughter who's taking care of her grandmother yesterday evening in clinic. She's trying to decide whether or not her 98-year-old grandmother with moderate dementia, can she continue to manage her at home, or is it a time that she might need to consider begrudgingly relocating her to a different location? So what are some of those factors that go into her decision making, as well as may go into the decisions your patients and caregivers are making. Well, first and foremost, we're hoping that there's some patient preference. And so, as I said, trying to assess what matters to them, where they would prefer to go. I will say I haven't had very many patients when it comes to nursing home placement say to me that they want to go to a nursing home. But what I have had people say is they don't want to be alone. They like to be engaged. They want to be safe. And in certain circumstances, those things may no longer be present for them in their home, whereas they might be present in a different location. And so that's where getting that information of their preference, what they're looking for, I can then have that discussion with them of how do we use that information to get where they want. But again, starting with that patient preference, but there are other things that we need to consider as well. There may be some, what I call intrinsic factors, some factors that are related to the individual themselves that may influence their caregivers or others to make decisions about where they go. And what's been shown in the literature and shown in practice is when it comes to caring for an older adult with dementia, things that typically wind up being breaking points, I guess, or decision points for caregivers are insomnia. So if the person with dementia is not sleeping at night or has a reversal of their sleep-wake cycle so that they're sleeping during the day and they're up at night, that's typically something that becomes challenging for caregivers, because for them it means 24 hours of being awake, because they're awake at night because they're concerned, and then they're awake during the day trying to do things as a caregiver. So that's typically a driver of looking for a different location. Incontinence, either urinary or fecal incontinence. As you know, many caregivers are either spouses or adult children. And as you can well imagine, most adult children haven't necessarily thought or planned to be able to provide that kind of care to their parent. And same can be true for spouses. So typically some incontinence may be when the caregiver starts to think, can I continue to do this? Or do I need to seek out more assistance or help or a different location? Again, I just had that conversation with a son caring for his mother yesterday as well, and trying to work through with him what we could do to kind of mitigate that factor. And then the last factor that's been shown to be particularly influential is if the older adult is wandering or has any other safety issues. So if they're physically aggressive or verbally aggressive sometimes, it may make it challenging to have consistent caregivers for them in the home, professional caregivers that are hired. If there's concerns about wandering, particularly wandering in the evening or other times when the rest of the family might be sleeping, that's also a concern, being wandering from home, being found someplace, safety concerns. So these are factors that the older adult may have that may make a family think, is this time to choose a different location? But there are also some factors outside of the individual that may also come into play in terms of the decision making. So who owns the home? Is the family paid to provide care to that individual? Do they have monthly benefits? And are those monthly benefits part of the household's financial expenses? So these examples I'm giving you are all extrinsic factors. All these extrinsic factors are financial. Obviously, they're not always all financial. But how did this come about that these even became part of the extrinsic factors that may be a consideration for family members? Well, as you may know, Medicaid, which is Title 18 of the Social Security Act of 1965, that was the Social Security Act that generated both Medicaid and Medicare. Just a little bit of clarification. Medicaid is funded by both federal and state governments, as opposed to Medicare, which is a completely federal program. And so with that state component, each state, because they contribute, get to determine the eligibility criteria for Medicaid, but they also get to look at who receives it in their states and what types of services Medicaid covers. Medicaid is the largest payer of long-term care, of nursing home care. Medicare does not pay for long-term care. They'll do short-term after a hospitalization or along those lines, but they do not do long-term care. That's Medicaid. So because of that state component with Medicaid, states were realizing that they were seeing a kind of trend that there would be older adults that during all of their working life, for example, were not needing state assistance. But when it came time for nursing home placement, all of a sudden they were applying for Medicaid, didn't have assets and resources, and then would get Medicaid to pay for their long-term care. So the states realized that some of what was happening is that older adults were, before going into a nursing home, turning over their assets to loved ones or friends that otherwise would have been turned over to the nursing home to pay for their long-term care, and therefore were able to claim that they didn't have the resources to pay for it and to be eligible for Medicaid. So states started developing what's called a look-back period, and many of them started at 3 years, but now many states are doing 5 years of look-back. And what that means is that when you apply for Medicaid, they look back at your finances for the 5 years prior and see if you had limited income all during that 5-year period. If, however, you had a house or other assets during that period of time, whomever is the recipient of those assets is then responsible for that portion of money that you gave them to then supply for the long-term care. So in effect, what happened is that Medicaid and the states changed some of the extrinsic factors. And so with that, that's why who owns the home has become important, because if it's the older adult with dementia and it's time for them to go to nursing home care, that house needs to be turned over to the nursing home to provide for their care. And so with this extrinsic factor that the states put on to try to influence how people make decisions of how they do their assets, it actually led to a different influencer, such that people now are turning over their assets earlier. Instead of waiting until the time they're to go into the nursing home, they may turn over their house as soon as their adult child starts caring for them, or years in advance, so that the 5-year time of look back expires before they get to the point of needing long-term care. And so that's one example of an external factor or a driver that was intended to influence older adults and their caregivers to not apply or not consider application if they in fact had the resources all along. And in process of doing that, it actually created a little bit of a different driver of just shifting forward how people transfer their assets and how they look at that. Let's go to another example to drive this home. So let's say you have an 86-year-old man. He has hypertension, he has COPD, perhaps some mild dementia and osteoarthritis. And for those chronic conditions, he takes several medications. What factors would influence you as the provider, as the clinician, to decide whether you're going to order his medications for 30 days or a 90-day medication refill? You know, Dr. Hart talked about the EHR probes that would encourage you to do generic versus brand name, but this is thinking about what size, what amount of medications do you give? And I venture to say there are several different things to consider. So one, again, is that patient preference. The individual may have a preference that they want to have either 30 or 6 or 90 days for various different reasons. They may choose one or the other. You may have a preference given compliance and believing that giving a 90-day prescription, you know, that with the individual having the medication, they're more likely to be compliant for that longer period of time rather than only having a 30-day running out and then maybe not getting their medication refilled in a timely manner. So you may be thinking of compliance issues, and that's why you want to do 90 days. But there may be some financial considerations. Maybe the patient, if depending on their healthcare plan, it costs them, 3 months worth to get a 90-day supply at one time. And if they have a limited income or a fixed budget, maybe they can't afford to pay 3 months worth at one time. And so it's better for them to do 30-day prescriptions so that it fits into their budget. Or perhaps they're getting their medications through something like the VA, where it costs them the same if it's 30 or 90. So why not get the 90 days, have the medication, have better compliance, but also then financially, it makes sense for them. So that's a financial consideration that might be a driver. And then there might be concerns about abuse potential. That may be another driver. If you have an individual, let's say, that you're treating them for depression or mood issues, you may not want to give them a longer prescription of, say, their antidepressant or anxiolytic until you know they're well controlled. Or if it's someone that you're treating them with an opioid or another potentially addictive medication, particularly given the crisis we're going through now, you may consider that you don't want to give them a larger prescription for the concerns that it may contribute to abuse potential. So all of these are different things we may be thinking of before we make a prescription choice of 30 or 90 days. We may not even be aware that some of these are things that are going through our mind. We may not be aware of things that our patients are considering, like financial considerations. However, these are all factors that are driving the decisions that we're making, and also the decisions our patients are making and hopefully verbalizing to us. So just as a kind of take home from this aspect, I hope that I've been able to make Dr. Hart's presentation a little bit more clinical and a take-home of applicable, how you may be using this, how this comes to play in your day-to-day. So first and foremost, we really want to assess the values and preferences of our patients, of persons with dementia, and have that be the grounding of our discussions. And so, as I said, having it with the patient, getting what they like, what they dislike, why, what issues or concerns, safety or other things that may be important to them. If they're not able to share their preferences directly, asking those questions of their proxy to have them articulate on behalf of the patient, given what you know of this individual, what do you think would matter most to them? What do you think gives them pleasure, enjoyment, why they might want to make one decision or the next? And then for us, as the person who is helping to create some of these choice environments, consider how there may be external factors, fiscal, caregiving needs, other things that may influence the choice environment, and acknowledging that, and perhaps if needed, helping our caregivers, helping our patients maneuver through those various choices to come to their preferences and be able to have their preferences fulfilled in the various environments that they have. So I thank you for your attention, and I'm going to turn it back over to Dr. Spolos, who I believe is going to lead our Q&A at this time.
Thank you, Dr. Rock. Thank you both to you and Dr. Hart for your excellent presentations. And I welcome Dr. Hart to also turn on her camera and unmute. Thank you. As we start this Q&A portion of the webinar. And I also want to encourage participants to pose their questions in the Q&A box for this final 15 minutes of the moderated session. And meantime, we do have a couple of questions that have come through, so I'll get us started. It looks like this first one is really to both of you, but starts by asking about the structural barriers that Dr. Hart referred to. And the question is, could you provide some examples of these structural barriers in the dementia care setting?
Yeah, so I think Dr. Walk just mentioned an example with a 30 and 90-day prescription. So you might have identified as a clinical problem that patients are not adherent to the medication you want them to be taking, and that they've expressed interest in taking, but yet they're not taking it. And so you might think of a number of different sort of behavioral interventions that you might be able to do to improve that. But if the person merely doesn't have money to pay for the copay, or the medication costs $10,000 a month, that's a structural barrier that no matter what you do in terms of changing sort of the behavioral environment for the patient, you're not going to be able to overcome that structural barrier. Similarly, related to Dr. Walk's talk, if you think about moving into a residential facility, and you might, based on everything that you've heard from the patient and the family, you think moving to a residential facility for dementia care is a priority for the patient and the family. You might be able to help them make that decision through a variety of different sort of behavioral interventions or behavioral sort of changes to the way that you talk about that with them. But if you live in maybe a rural environment where there's no specialized inpatient facility that's appropriate for dementia care within 2-hour drive, that's a structural barrier that no matter what you do behaviorally, you're not going to be able to overcome. If you want a caregiver, if you think it's important for a caregiver to be there for a serious illness conversation of some kind with a patient in a joint meeting, but you can't get the caregiver to come to the meetings or the clinic appointments, you might think of a variety of different behavioral interventions or ways that you might change that environment for the caregiver. But if the reason why the caregiver can't come is because you only have clinic appointments 9 to 5 and the person is at work and is unable to take an hour break to come over for a clinic visit, that's a structural change that you, until you change the structure and the sort of structural environment for that caregiver, they're not going to be able to just make a different decision, if that makes sense. Hopefully those examples are helpful.
Thank you, Dr. Hart. I wanted to give Dr. Walk a chance if you would like to add on to the answer to that question, please.
Thank you. No, I agree with the comments, and particularly the last one, right? We oftentimes think that things are just the way it is, right? We just offer office hours during this particular time when there is an option to do off hours, or particularly given the world that we live in now, and it's true for so many caregivers of persons with dementia, whether it's an in-person or a virtual visit, that might be another way to overcome a structural barrier. And that's one that we've been using more and more, whereas before, if you're older adult, let's say, who had moderate dementia, they're afraid to leave the house, or they have some physical limitations that make it challenging for them to get out, or maybe you need to call an ambulance. It was quite a barrier sometimes for a caregiver to have someone come in to be assessed, to be seen, to check and see where they are now compared to where they were last time. And with the COVID pandemic and everything becoming virtual, so for so many of my caregivers and for patients, now they can be at home. They're not afraid and frightened because they're coming to the office or someplace else. They don't have to, get in the car and travel and come over. And so for the caregiver, for many times the patient is more relaxed. They can put they can set up and have the patient right there and the camera is on them. But then also they don't have the travel time and other things that would make it perhaps a all-day affair to come in between getting them actually out the house and calming them down after they came back in. Now it's just a matter of turning on a camera, having the visit, us being able to speak with the older adult in their comfort of their home, really being able to see how they are in their environment and not so frightened, and then still being able to make recommendations and treatment choices. So I'd say that's another way of overcoming a structural barrier that many of us hadn't necessarily thought about before, but then everyone started doing afterwards, and recognizing now that part of the reason why we don't think that that's going to go away is there is a certain population, particularly individuals who with dementia, that this is it's so life-saving and beneficial for them to still be able to get beneficial care, to get assessment, to get advice, but doing it in a way that doesn't create more stress for them or for their loved one.
And I think this also relates to sort of a maybe broader point around, if you aren't able to get the insight that Dr. Walk is describing, then because many of us do work that we are not part of the community that we are trying to help. And I think it's really important to recognize that and to have sort of humility around that, so that we either do mixed methods research, we talk to the stakeholders, that we include community members on the research teams or as people sort of informing the research. Because especially when you start sort of manipulating environments and experiences for patients and caregivers, it's really important to have a good handle on what the barriers are, what the potential implications of those changes might be. And that's true even if we haven't sort of thoughtfully created the environments that they're moving through the healthcare system in. But I just want to say, as a plug, I think it is really critical to make sure that we don't assume that we know everything, and that we really get feedback from the people who are involved, both to give us insight into how we might make it better, but also to make sure that we're not doing harms through our sort of manipulations.
Thank you very much. So we have another question here, which is really getting at the heterogeneity may be driven by socioeconomic factors or cultural factors around patient preferences and that affect their long-term care seeking behavior. And perhaps you could speak a little bit to how you manage the heterogeneity that you might witness in your care practice, Dr. Walk, or Dr. Hart, how behavioral sciences can adapt to this idea that your patient populations are heterogeneous.
So nice tie into the comment that Dr. Hart was just making, right? We have to start with a level of a culture of humility and recognizing that we're not going to know everything about every patient and their background. In the literature, you will see that it's more common in cultures of color, so African American, Latino, Asian cultures, that older adults are not are cared for at home as opposed to being in a long-term care facility. However, that's obviously not 100%. And interestingly enough, while there's that phenomena in the United States, we're also seeing a little bit of phenomena of the parents still in the home country, let's say, and the children may be here, and therefore then back home, they either wind up paying for someone to come in and care for them in their home, or have to go to alternate location because they're not there to physically care for them. But starting with that knowledge, I mean, that's part of what, when I'm generating or asking from the patient's point of view, what matters most to them, and obviously the caregiver is typically there or able to hear, also getting a sense of how does that translate for them, right, in terms of the person that may need to make the decision. So it's not uncommon that I'll have family members say, you know, I'm not going to send them to nursing home. I'm going to take care of them at home. And so that's fine. Then what do we need to put in place to help you be able to do that at home? Or as in the case of one of the granddaughter I mentioned to you that I was speaking to last night, who happens to be African American, to take care of her grandmother at home, but is now recognizing that it may be more than what she's able to do. So having that conversation of recognizing we already have these services in the home, they're doing this. If you get to a point where you feel that you cannot do that, then we may need to consider this next location of moving. So at least how do we tailor that? Start looking at places now, find some place that you think would be most acceptable to you and your grandmother. And at least you know you have that as an out. You may not choose it, but for many people, just even knowing that they have another choice helps to alleviate. And just even having that discussion with her, with saying, it's okay, you've been doing it. And if it gets to a point that you can no longer, then I will help you with that process as well. So it is recognizing that it's not a one size fit all. And for some people, they have a lot of family support. So being at home or other places works. For some people, like this one I'm talking about, she's by herself, still working, has, a relatively demanding job. And with her grandmother being moderately demented, not sleeping well, we're managing that. But if that doesn't get under control, she's starting to think it might be a time for a different location. So I think you really just need to know and ask what's their value system, what's important to them culturally, what would be acceptable. In some cultures it would be unacceptable if you didn't take care of your loved one. It would be a matter of, shame or not being a good child or a good caregiver. So you need to recognize and know all that so that we make recommendations and provide assistance that respects that and works along with that, as opposed to setting up another barrier.
And as we're thinking about sort of broadly creating sort of choice structures that are applied to sort of large populations of people. So for example, systematic changes in what the default is, or sort of like what happens if you don't opt away from it. It's important to recognize that you have to also protect the people for whom that default is not appropriate. So you have to think about sort of what are the barriers that are required to sort of opt away from that default. It's also why it's really important to think about sort of how we structure our conversations with people, because we as clinicians, or people who are clinicians who are presenting sort of these one-on-one choice environments to people, we actually tested the choice architecture competency of our sort of terminal year residents at Penn a couple of years ago. And this is published. I can figure out a way to disseminate the link, but we actually found that people are physicians who are about to sort of embark on sort of full practice are really not very good. They don't know how to anticipate the effect of choice architecture, which means that if you fundamentally have to sort of put together the building blocks of understanding what's appropriate and relevant and value aligned for that particular patient and that particular family, and you have to know sort of, okay, now that I understand that, I also now have to understand how am I going to change their choice environment to promote that decision making, so that I don't just provide sort of an information dump to them, but I facilitate their decision making so that it becomes value aligned. If you don't know either of those things, you're in trouble. So you have to have both of those building blocks in order to get to a place where your conversations, sort of the one-on-one conversations, are going to promote value-aligned decisions.
Thank you. I think that actually answered another question, Dr. Hart, that had come up around understanding the drivers of the patient's medical care decision-making, and then how that influences the clinicians or the healthcare practitioners. So I wanted to turn last, we have about just a couple minutes remaining, so it'll have to be a quick answer. I wanted to turn next to dementia diagnosis and detection. So we know from our evidence that this is often at severe and late stages of disease, and knowledge about what the symptoms are by the persons living with dementia and their care partners is only likely part of the reason why there is delay in seeking care. And so the question is, how might behavioral sciences be utilized to promote earlier detection and diagnosis? And this might be on the patient side or on the provider side.
Dr. Watt can probably provide sort of firsthand experience with this, but I'll say that clinician behavior is a huge target for behavioral science change, because especially for things like screening on systematic levels. So screening is one of those things that's sort of the low-hanging fruit in the sort of nudge world, because you can find ways to make it, to reduce the friction. So you're not asking sort of smart people to be more thorough, that you're sort of taking away the friction that it would take to screen people through sort of more automated built-in systems. And that's really where a lot of promise to date has been in sort of nudge units and sort of nudge interventions in healthcare systems. And that might be to have sort of, just like a default screen or an alert that pops up, or a sort of forced choice. Is this person appropriate for dementia screening when they come to their primary care office? And so those sorts of things are really nice targets for behavioral science interventions.
Thank you, Dr. Hart. So we have about 1 minute. So I'll leave the last comment for Dr. Walk if you want to weigh in on that.
So what I was going to just say quickly is that, so the United States Preventive Task Force, for example, weighs in heavily on that, right? And so when it comes to dementia, we know that right now that that assessment is not, it's a grade C level of evidence, right, of doing dementia screening. And so if it becomes a higher level, or there are quality metrics from facilities, from payers that would pay for screening or doing better, that's another driver that would influence how systems and clinicians to then screen and look for dementia and be able to start the process earlier on. So that's a external one that could easily influence that way, to get to that quick answer.
Thank you. Well, that wraps us up. I just want to take the last 30 seconds here to again thank Dr. Hart and Dr. Walk for their excellent presentations and the great discussion. And thank you to all our participants for joining us today.